I'd like to welcome everybody back. This will be our video lecture for pathophysiology. Hope everybody's doing well. Hope everybody survived the snowstorm. And let's just get started. Pathophysiology. So let's talk about homeostasis to start with. So here you have homeostasis. You'll have your afferent pathways and your efferent pathways. You have receptor and effector, right? And so we mentioned this in the past video about how you could take a reflex hammer and you could strike a knee. And you can strike that knee, and then that will trigger this receptor till there's pain, goes to the control center, comes back out, down the effector pathways, the efferent pathways, and the response to that change would cause your knee to kick out, you know? And so basically homeostasis through receptors, the control center, and your efferent pathways keeps you at a regular base, right? Allows your body temperature to be at that 98.2 or 98.7, might be even 99 for some people, right? But for instance, let's say you get sick. Let's say you have a bacteria and you're sick. Well, the body would pick up on that and say, hey, let's turn the thermostat up because, you know, he's sick, and let's try to create an environment that's not very good for bacteria. Bacteria doesn't like heat and it doesn't like cold. Most bacteria does anyway. And so the body will actually try to, make you have a fever to try to create an environment that's not very hostile to bacteria. So that's what homeostasis is. We have cellular metabolism to talk about. We're going to talk about glucose, oxygen, and energy, and how it affects the cell. So glucose is your primary fuel. It can be compared to that of gasoline in a car. Oxygen is a catalyst. And so what that does, it just increases the rate of a chemical reaction. So if you have oxygen there, it produces energy much quicker, right? And so it just helps that. So glycolysis. So if we have glucose that comes into the cell and there's no oxygen there, it's still going to produce pyruvic acid. So it does not require O2. It's the first phase. And the first phase is glucose is broken down in the cell and produces pyruvic acid. It doesn't require oxygen, but leads to something else, meaning another definition, and that's called anaerobic metabolism. So anaerobic means without, in this case, without oxygen. Glucose comes into the cell, doesn't see oxygen. Pyruvic acid through glycolysis is made. The pyruvic acid is going to change over to lactic acid. And you have 2 moles of ATP. And what you just need to know about that number is 2 of something is not a lot. So you don't get a lot of energy. So the byproducts here is going to be acid and a small amount of energy. The opposite of that is aerobic. We have glucose comes in, meets oxygen. Glycolysis occurs through making the pyruvic acid. We're going to get 36. So 36 is a lot more than 2. So you're going to get a lot of energy. You're also going to get some more byproducts here. You're going to get heat, carbon dioxide, and water. Heat's going to be used to keep the body warm. Water is going to be shipped over to your plasma. So let's talk about the sodium potassium pump, and we have already. We've talked about it in the schoolhouse of cells, but let's talk a little more about it so that everybody understands how important it is, how it kind of works, and when it fails, why is it bad? And so Remember, you have sodium. That's your primarily positively charged ion that likes to live outside the cell. And then you have potassium. It's also a positively charged ion, and it likes to live inside the cell. So in order to perform, though, in order for this not to fail, so what could cause the sodium potassium pump to fail? Well, anaerobic metabolism will cause this sodium potassium pump to fail. And the reason why that is because in order for this to work, it requires energy. And it requires energy because of this. Both sodium and potassium are both positively charged ions. In the world of chemistry, they should push each other away and not attract each other. So when potassium's inside the cell, it does not attract sodium. Now, sodium wants to come in because there's no sodium in there. It wants to go where there's not a lot of it there. And so you have this concentration gradient. And so once you push sodium inside the cell using energy, guess what? Sodium's quite content in there, and it won't come out because it's like, well, there's not a lot of us in here, so let's hang out. As a matter of fact, let's bring some more people in because we're in here and there's still not a lot of us in here. And potassium kind of wants the same thing. Even if it's been pushed out of the cell, it kind of wouldn't mind going back in because why? It got kicked out. Not a lot of potassium in there. So it both kind of want to live there, but they both can't live there. If sodium continues to stay in that cell and not come out, then water is going to follow sodium. Remember, this is a semi-permeable membrane. It does not block water. It blocks sodium. It blocks potassium unless there's channels to let them in and out. It's going to block all types of other things, but it can't really not block water. And so water is going to follow sodium into that cell, and it's going to keep filling and filling and filling till the cell ruptures. So there has to be a way to pump sodium out and get potassium in, and there is. It's a sodium potassium pump. But if you become anaerobic metabolism, then the energy, it needs 36 moles to work. If it only has 2 moles, it will begin to fail and cells will begin to die. Let's look at, again, to kind of recap it. Aerobic metabolism versus anaerobic. Anaerobic, you get heat. You're going to have waste product of CO2. You're going to get water. In anaerobic, you have lactic acid, right? And very little energy. When we look at the definition of perfusion, we're talking about we need O2, glucose, and other nutrients inside the cell, and we need the waste to be removed from the cell. And that really starts from the airway. Remember, I want to talk about this because it's huge. We have FiO2. And when you see FiO2, I want you to think of the I as inspired. You see this FDO2, I want you to think the D is delivery. FiO2 is expressed in a decimal form, so this non-ring breather provides a concentration of 95% of oxygen when used. 0.95 is the FiO2. But it's used for inspired, meaning the patient can still deliver oxygen down the alveoli. The FDO2 in this case is somebody who is in respiratory failure, and we must deliver that oxygen. And here's a BiPAP that's forcing that oxygen down to this patient who's probably, has congestive heart failure, something like that. that needs to get that oxygen down to the alveoli. We have to think about the environment. Remember, we need 21% oxygen to breathe. Things that disrupt that, carbon monoxide, cyanide. Both would disrupt a way for us to bring air in. It's just an example. There's other environmental toxins out there, but these are the two big ones. You need a patent airway, right? And so when we define a patent airway, we're talking about an airway that's clear of blood, secretions, vomitus, tissue, bone, and teeth, right? Nothing to obstruct the airway in order for us to be able to deliver oxygen down to the alveoli. Let's look here. We have the epiglottis. And so epiglottis right here is above the larynx. Here's your tongue, your epiglottis. Your epiglottis. Here's your trachea right here. And you can see the epiglottis sits right here on top, right? And it needs to, because its function is to keep food, liquid out of the trachea, right? So when we eat, it covers it. When we're drinking, it covers it. But there are times we don't see it as much as we used to. But we used to see infections of the epiglottis that would cause it to swell and become inflamed. We called that epiglottitis. And so that would be an upper airway obstruction. Here we have the larynx. And so you see the larynx right here. The larynx contains the vocal cords. The most narrow point in adults is right at the level of the vocal cords. These are your vocal cords right here and right here. And sometimes we have something called laryngeal spasms. And that's when the vocal cords spasm close together, or spasm and close together. And we see this in drownings. We see this sometimes when people choke. They're going to close off in order to protect that trachea from receiving any fluid down. Child's less than 8 years of age have a cone-shaped airway. It's most narrow at the cricoid ring. The trachea here is distal to the larynx, so it means it's just below the larynx. So there's your trachea, there's your larynx. And we can see a better picture here. We have the thyroid cartilage here. There's your trachea. Comes down to the carina where the right and left bronchi branch off. The smaller these bronchioles get, call them bronchioles. Bronchioles are lined with mucus, right? Comprised of smooth muscle. That mucus allows oxygen to really help it get down to the alveoli, keep it really slick. And so occasionally that mucus and that lining of the trachea or even the bronchioles can become infected. We call that tracheitis or bronchitis. So here we have some bronchitis here that's affecting the bronchioles. Asthma is a little different. It's usually an allergic reaction, not an anaphylactic. Asthma can be triggered by either emotional or by environmental allergens. But see, so you have your really nice open bronchiole here with good smooth muscle. Here that bronchiole is inflamed. It's becoming smaller. It's got mucus right here. So we're going to have wheezing, increased airway resistance, increase in CO2. So we have that hypercarbia happening. Emphysema, increased airway resistance due to obstruction or collapse of the alveoli. See these alveoli? These are normal. They're kind of small, right? Look how swollen and destroyed these are over here. They've lost their compliance, right? They've lost their compliance. And that surfactant that covers the alveoli, and that allows them to keep a good surface tension to keep those alveoli open. We've lost that with emphysema. All right, so here we have some alveoli. See, look, each alveoli has its own network of capillaries, and they're quite, if they're not, haven't been destroyed, then you have a lot of them. The surface of the alveoli are wet. It makes diffusion easier, and the distance between the capillaries and the alveoli a very short distance from each other, and that allows for that oxygen and carbon dioxide exchange. When we talk about compliance, it's the ability of the chest wall and lungs to stretch. These balloons here stretch. You can still stretch them out more. They're harder to stretch open. So here we have a very high compliance, and this is very low compliance. It's hard to, once you get that big balloon, to keep getting it bigger and bigger. On these short ones, you can, you know what I mean. I don't think I need to go on and on about that. When we talk about the thoracic cavity, it plays a major role in ventilation. And I'll show that on a couple of slides coming up. Structures needed and necessary for ventilation. Well, neck muscles, you need your ribs. Diaphragm, which is responsible for like 75% of breathing. Your sternum needs to be intact. Your vertebrae, the pleural linings, the visceral lining, all of that needs to be there and functioning. All that's mechanical, right? You need all that mechanical things to make breathing good. Let's talk a little bit about Boyle's Law. And Boyle's Law, basically what it says is that increasing the size of a closed container will decrease the internal pressure and creates a negative pressure. Right? So the larger the volume, the decrease in pressure. So when you inspire, you're creating a higher pressure, and when you expiration, you're having a lower pressure. Right? And let me go to the next slide. I can explain it. We'll walk through it. We'll walk you through it. All right. So here we have at rest. All right. The diaphragm's relaxed. The alveolar pressure is equal to atmospheric pressure. If you want to know what that is, it's like 760. Right? And so everything's equal right now, right? So during inhalation, the diaphragm contracts and the external intercostals contract. That chest cavity is going to expand. Right? So it's got to expand to allow those lungs to fill with air. Right? And if you notice, it says it expands and the alveolar pressure drops below atmospheric pressure. It allows the air to flow into the lungs. What you're doing is you're creating a negative pressure to allow oxygen to be pulled in down to the alveoli. You're creating that negative pressure to allow that to happen. So negative pressure. But down here, you're going to increase the pressure. And you're going to create the opposite effect. After air has come down and in, and you reach 754. Here we have 756, and we're coming up just above atmospheric pressure of 760 to be able to create the effect where we can get air out of the lungs. And so you say, well, why is all of that important, right? Well, it's important for this reason. Let me back. I thought I had a better slide. Maybe I don't. And that's okay. I can use this one. So think about it. If this pressure, when we take a breath in, is more negative, creating a vacuum. If you end up having any type of trauma that opens this chest cavity up to the outside world, right, then this is going to become so negative that it causes this lung to collapse. And so even though I didn't touch the lung with a knife blade, I opened up enough to where air can enter the chest cavity, causing it to become so negative that the lung collapse. So you don't necessarily need an injury to the lung to cause the lung to collapse. All right, exhalation is normally passive. Passive means it normally doesn't require energy, right? Well, that's great, but if you're in a situation where your patient's in distress and they have to have forceful exhalation, then that is actually going to lead to becoming an active process using energy that we didn't account for. So think about it. The patient is in anaerobic metabolism. The sodium potassium pump is failing. We don't have the energy to work it. And now the patient's working so hard to exhale that we're having to produce energy that we normally don't have to produce in a situation that our body's not making energy. It's not making ATP. It's making 2 moles versus 36. So think about that. So airway resistance, the more difficult it is to move air through airways. It requires the patient to work harder to breathe. Just what I was talking about a second ago. Look how open this airway is right here. Nice open airway. Good smooth muscle. Now look at this one. Very narrow. Smooth muscles constricted. And look at this. This is an airway wall right here. Look how constricted this one is with mucus and all that in there. The potential space between the pleural cavity maintains a negative pressure. So if you're looking at, here is the visceral pleural. This is the parietal pleural right here. It's this space right here we're talking about. That space in there. And that's what I was talking about. It can become so negative that it causes that lung to collapse. This was the slide that I was looking for a second ago. I was going to show you. Let's talk about some definitions. Let's talk about minute ventilation, tidal volume, and frequency of ventilation. So minute ventilation is the amount of air moved in and out of the lungs in 1 minute. Tidal volume tidal volume is the volume of air breathed in with each individual breath. And then frequency of ventilation. So this is a number of ventilations in 1 minute. right? So this is about amount of air in 1 minute, and this is the number of ventilations in 1 minute. So let's put these definitions to work, and let's examine maybe a patient who's stable versus a patient who has not as stable and they have very low tidal volume. But let's look at this. A minute ventilation, well, what it equals to is tidal volume times the frequency of ventilation. So tidal volume on an average adult is 500 milliliters. So if we multiply that by 12 breaths per minute, that gives us about 6,000 mLs or 6 liters a minute. Kind of gives you an idea. But this is where gas exchange occurs, right here, inside the alveoli, right here at the capillary bed. And so what we really need to understand and truly get is alveolar ventilation. And so this is the amount of air moved in and out of the alveoli in 1 minute. Okay. Well, we have to think about dead air space, and that's the amount of air that doesn't make it to the alveoli for gas exchange. That's the definition for that. So if you look at that, about 150 milliliters of tidal volume is lost to dead airspace. So if you take 500, you minus 150, really, you're only using or getting for gas exchange about 350 mLs of tidal volume. So remember that, because we're going to go to the next slide and see how that's important. Here we are. So let's look at alveolar ventilation. What it's equal to is tidal volume minus dead air space, and we'll multiply that by the frequency of ventilations. So we have 12 per minute, and we have 500 for tidal volume. So we're going to take 500 minus the dead air space of 150, and we're going to say 12 for frequency of ventilation or respiratory rate. And so that's going to give you 4,200 mLs, about 4.2 liters. So out of that 6,000 milliliters breathed in and out, only 4.2 liters reach the alveolar for gas exchange. All right. So that's for normal. Let's paint a picture of somebody who's not normal, somebody who's hypoxic. So here we have a tidal volume of around 200 mLs. Remember, 500 was normal. Out of this tidal volume, we got to get rid of this dead air space. So out of 200 mLs, we're going to minus 150, and we're going to multiply that by 28. That gives us only about 1.4 liters per minute. We need twice that amount for normal. So this is what shows is why and how important alveolar ventilation is in the scheme of things, but also shows you that this is your patient breathing 28 times per minute who's in respiratory failure, who's going to be dead if you don't recognize that they're breathing 28 times per minute with less than an inch of chest rise and fall, and you put a non-rebreather on them. They're going to die. They're not going to get that non-rebreather, that oxygen down to the alveoli where it needs to be. They're going to die. As an advanced provider, if you didn't learn that in EMT school, you have to learn it now. You have to be keenly alert to the ones that are knocking on failure's door or on failure's door. You have to be ready to bag somebody who's staring at you because they're dying. You have to be prepared to notice that. So that's why I say assessing tidal volume is important, if not more important than respiratory rate. Respiratory rate, I don't, never have cared about. I look at chest rise and fall. And if it's less than an inch of chest rise, I'm bagging them. If it's more, I'm going to try something else. I'll try a non-rebreather. But if their chest can only rise 1 inch or less than 1 inch, we have to do something to fix that. But, you know, the book is going to tell you, and they're going to tell you about these respiratory rates here. So we're going to assume that any adult who's breathing more than 40 times per minute is in failure. And that makes sense because even if they're not in failure, if they're breathing 40 times per minute, they're going to be in failure really soon. And we're going to say the same for pediatrics that breathe greater than 60 per minute. All right, let's talk about regulation of ventilation. Let's talk about receptors. These receptors read oxygen, CO2, pH. Breathing is mostly involuntary. So there is the way the body, causes us to breathe. There's 2 receptors. One is called the central chemoreceptor. The other one is the peripheral chemoreceptor. Central chemoreceptors are located in the medulla oblongata, right? And then your peripheral chemoreceptors are down here in your aortic bodies. Central chemoreceptors they're going to read hydrogen, carbon dioxide inside the central spinal fluid. They're going to be testing that up here. Your peripheral chemoreceptors, they're going to be reading carbon dioxide and hydrogen as well, but they're additionally going to read O2. So when we talk about a hypoxic drive, normally a person's rate and depth of breathing is regulated by the amount of carbon dioxide in the blood. It didn't say O2. It's normally regulated by carbon dioxide. And why? And so the reason why that is that there's residual O2 in the lungs and the capillaries. But I had an incident happen to me over at Rockdale. I had a patient that was really sick. They were in respiratory failure. They were on a ventilator. And we had to take them over to the CAT scan. And so we had to go to CT. So I called respiratory. It's like, hey, you got to go to CT. And they said, okay, I'll be there in a minute. And they show up and they have something called an auto vent. An auto vent, it's a really simple device. It's small. It's great for when you're doing transports. You just put in the tidal volume and how many times you want them to breathe per minute and set it and go. And so we hooked this up and I'm ready to roll. I got my cardiac monitor, pulse ox right there on the bed. I'm ready to go. But the first thing I did was I looked at chest rise and fall and I didn't like it. The patient's chest rise just it wasn't rising at least an inch. And so I mentioned this to the respiratory therapist. I was like, hey, I don't like chest rise and fall here. Are you sure this auto vent is set appropriately? And of course they were, sure, yeah, it looks good. It's on. Never once did this respiratory therapist look at the patient's chest. They looked at the auto vent, at the settings. Well, it was about 2 minutes before alarm bells start ringing and the pulse ox is in the 80s. And I'm like, nope, your auto vent's not working. Took it off, put the patient back on the vent, and they went and got another auto vent. There's enough of residual that the body has to where it can wait a while before things start happening. Not the case with CO2, and that's why the body uses carbon dioxide as its major regulator, right? And if we had CO2 monitoring there, I would have known instantly that it wasn't working. So let's look at chemoreceptors. All right. So if you have a drop in your O2 level, chemoreceptors in the carotid and aortic bodies report this to the medulla. The medulla says, okay, let's increase the respiratory rate and depth of respirations until more O2 is available to enter the blood. And you say, well, Instructor Morris, if that's the case, how can we be on that carbonic drive? Well, most healthy people, CO2 is the way to go. Now, occasionally on your emphysema patients, there's such a high CO2 level in the body that the body will switch over to reading oxygen. And that's part of a hypoxic drive. It will start reading oxygen on those patients. Why? Because CO2's become unpredictable. These patients retain so much carbon dioxide that the body is pretty smart and it goes, no, we're not reading those anymore. Here we have an increase in CO2 or a decrease in pH. And when we talk about acid base and we talk about pH, pH means the potential for hydrogen. And what that really means is the potential for acid. And the pH scale one sec, my bad. One second. All right. So here we have a pH scale or potential for acid, right? So as these numbers drop, we'll call it 1, 2, 3. Then we'll have like 8, 9, 10. All right, so as these numbers drop, the patient becomes more acidotic. So if you add like 1, 2, 3, those are very acidic numbers. So as this pH scale starts to drop, that means the patient is becoming more acidotic, which normally means when you have a higher rate of carbon dioxide in the blood, your potential for hydrogen or acid becomes better for acid, as you can see. So the chemoreceptors in the medulla pick this up. They send a message right over here. Let's increase the rate and depth of respiration till more CO2 is exhaled and the pH comes higher. So we want to raise that pH all the way back to 7.5. That's where blood is normally, 7.35 to 7.45, somewhere like that, to where the patient, is homeostasis, and that number's good. That's how chemoreceptors work. All right, y'all, we're going to stop the video right here because I am going to do a separate video here about acid base, and that's where we're headed next. And so I hope everybody's doing well. Hope you enjoyed the video, and I will see you guys soon.